Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel. What's your favorite way to assess the hips? Let's say somebody has hip pain, maybe some sort of snapping hip, or they feel a pop on the inside of the groin area, or they just have general hip pain. What's your favorite way to start evaluating that problem? And I just want to put it out here that as acupuncturists, it is not our role to diagnose hip or any kind of problem. We should be sending our patients to a medical doctor if we believe that something is wrong that needs to be evaluated with imaging and further orthopedic testing. We really should be there to help restore function and not to give a medical diagnosis. In the state of New York, where I practice, it is not allowed to give a medical diagnosis, so I don't even try to give a medical diagnosis. If I suspect something is wrong, something needs to be checked by a professional, a medical doctor, an orthopedic specialist. That is where I'm going to send the patient. Once they have had a diagnosis, maybe they've had imaging, maybe the orthopedic expert has just done some orthopedic assessment and said, I think it's a possible hip labral tear. At least we have a functioning diagnosis and we know what to expect from our treatment as far as results. With a hip labral tear, I don't ever expect to get them to zero pain all the time, but I do expect to get them to zero pain most of the time. So that said, my favorite way to assess a hip is with passive range of motion on internal and external rotation of the hip. So I want to put the patient on their back with their hip in flexion at 90 degrees and do what some of you might call a Faber test, which is flexion, abduction, and external rotation passively, and have the patient tell you if they feel any discomfort at any point, tell you, and you stop right there. It is not specific for anything. The doctors will want to investigate if that is causing pain. But once they've been evaluated and you know that they have that pain, that's what they're there for. We want to restore function. So we do the Faber test. We do the hip external rotation and passive range of motion, where we are moving their hip. And we want to get them to an end range that's comfortable, but you feel where the resistance is. And hopefully that's going to be better than a 45-degree angle. Better would be 50, 60, 70. I've seen some people where we almost get to 90 degrees of hip external rotation passively. Then we want to test hip internal rotation. So the knee is pointed straight up to the ceiling there. The hip flexion is at 90 degrees. And we gently go into passive internal rotation, and we hope to get them to about 45 degrees of hip internal rotation. The older the person is, the less likely you're going to reach 45. If you get beyond that, that's great. That's really good flexibility. You'll see that on athletes and young people. But your you're really looking for their baseline. So you're hopefully testing the unaffected side first to see what normal looks like for this person. And then on the side with the problem, you're going to compare. This is my favorite way to assess a hip. Now, I'm not saying I will not at some point muscle test things, do length tests for adductors, hamstrings, etc. But for a hip problem, I am not as concerned with muscle tests and strength tests of glute medius, glute minimus, TFL, adductors, all of that. I want to see what passive range of motion will show me, because it's my opinion that a muscle could test strong and still be short. It could still be contributing to the hip dysfunction. So I really want to test length. So by doing that, when we're testing external rotation of the hip, what is resisting that ability to go into external rotation? Sort of like when you want to sit cross-legged on the floor. The internal rotators are going to be the inhibitors for hip external rotation. Primarily, I'm thinking about the TFL and the gluteus minimus. TFL is flex abduction and internal rotation. Gluteus minimus is pretty much the same thing. Some people agree that it flexes the hip and some people don't, but we know it abducts and internally rotates. Those are my two go-to muscles for restriction of hip external rotation. Now, what else could inhibit external rotation of the hip? Adductors. Adductors are obviously going to adduct, but they internally rotate the hip. I've talked in another episode about obturator nerve issues that will cause one leg to flop open because the adductors maintain your knees in a parallel state where the knees point forward. The adductors are maintaining that and being innervated by the obturator nerve. When there's an impingement of the obturator nerve, you will see one leg flop open because the adductors cannot hold the leg in a parallel position. So you have one foot external, flopping open. You have the whole leg flopping open. So that adductors are internal rotators. So when you have a problem on passive external rotation of the hip, look at adductors, especially if you've already worked on TFL and gluteus minimus. Gluteus medius has anterior fibers that help internally rotate the hip. So the gluteus medius can get you a little bit more flexibility if you're working on that as well. Those are going to be the primary muscles that I'm going to look at that will restrict hip external rotation. So once you've looked at that, now your internal rotation restrictions are going to primarily come from deep rotators. It's going to be muscles like the piriformis, the gemelli, the superior and inferior gemellus, the obturator internus, possibly the psoas. The psoas is causing trouble all day long. So consider the psoas because of its attachment on the lesser trochanter, the femur. It, when it's tight, is pulling the hip into external rotation and resisting internal rotation. There are other smaller muscles to consider, the obturator externus or the obturator, the quadratus femoris can also externally rotate the hip. But when you're restricted on internal rotation, the glute max externally rotates as well. The posterior fibers of the gluteus medius externally rotate the hip. Those are all things to get you a little bit better mobility on internal rotation, but primary restrictions that will cause hip pain are going to be deep rotators like the piriformis, the gemelli, and the obturator internus, and the psoas. Psoas pain is going to be obviously more in the groin area an impingement feeling there. And then obviously the deep rotators with hip dysfunction are going to be more greater trochanter or SI joint pain. But those are going to be my go-to muscles for restriction of hip internal rotation. So that's where I like to start. And it's going to get you a lot of guidance, going to give you a lot of guidance just doing that passive range of motion on external internal rotation of the hip. Now, I also love this test when I'm working with an athlete who is not in pain and is just looking for athletic performance. They're looking at better flexibility, agility, stability, avoiding injuries. This is going to expose what is tight and restrictive, regardless of their strength. They're already strong and they're not in pain. They're looking for sports performance. One of the best things you can do for their hip stability and agility is to improve their hip internal and external rotation. Obviously, you're going to work on quads and hamstrings too. Hamstrings can restrict external rotation of the hip, especially the inner ones. The quad, like rectus femoris, can restrict hip external rotation. I could probably make an argument that it could restrict internal rotation as well, because it's right in front, right down the middle. So when it's tight, it could be restricting either direction. So you're going to look at the quads for when you're looking for perfection. When you're just assessing somebody for hip pain, look at the dysfunctional side, the side that doesn't externally rotate as much, or doesn't internally rotate as much. I use that assessment for deep gluteal syndrome, like a sciatic issue, to confirm that the affected side is being influenced by tight, deep rotators. So my go-to for hip problems is always going to be passive range of motion on internal and external rotation. It helps you assess most of the muscles that you want to consider. So if nothing else, it's the first thing you should be checking. And then if you want to dive deeper into what those restrictions are that you've exposed, then you can do that with length testing and muscle testing if that's what you're really looking for. I like to think in groups of muscles and treat groups of muscles because I believe they work synergistically. So even if they're strong, they have some underlying level of dysfunction that I want to assist. Muscles, as they get overused, they shorten. So this is why passive range of motion is going to be a great assessment. It's going to expose muscle shortening. And muscle shortening is weakness, right? So if you have partial contraction of a muscle, even if you're strong, it's not at its optimal level. This is where sports performance can be enhanced by treating healthy muscles with electric stimulation of the motor points. So for me, my go-to for hip is going to be passive range of motion. Occasionally, I'm looking at adductor length testing. Occasionally, I'm looking at hamstring length testing. Sometime I might want to test strength of abduction or single leg stance. But most of the time, I can figure out that the TFL and glute min are too tight just by passive range of motion. If I feel I need to impress upon the person I'm treating that this is the problem, that I might muscle test it just to show to them the before and after. But when I'm just thinking about what do I want to treat, and they already trust me, I'm just looking at range of motion. That will tell me everything. The hip internal rotation restriction is going to tell me so much about what's going on with deep rotators and psoas. Adductors come later. Adductors are not usually a number one source of pain, but you may find that you do need to treat them if they're having some sort of popping in the internal hip area, or groin pain. So for groin pain, look at adductors for sure. Look at psoas and adductors. So I guess that's it. I just wanted to put that out there, that I think you can save yourself a lot of time by first testing range of motion on external, internal rotation, and just go from there. Frequently, you don't need to go further than that. It will expose the problem. And it's interesting when you think about all the muscles of the hip, how many of them do some function of internal and external rotation. Very few muscles that don't. I think the pectineus is one that comes to mind, that only adducts. I'm not aware of pectineus helping on anything else, like internal or external rotation, but a lot of the adductors are internal rotators. So that test for external rotation is going to expose an adductor issue. Anyway, so that's my 2 cents. Hopefully that helps you streamline your assessment, especially if someone comes in with diffuse hip pain and you're just not sure where to start. Start with internal, external rotation. It's going to help you narrow down where the dysfunction is. And if you're working on pro athletes, you should be length testing the hip, because they're strong on many of the muscle tests, but the length testing is going to expose their weaker side, the side that's being overused, the side that has more muscle shortening. So if you want to help them on sports performance, look at length testing, look at passive range of motion. It will expose the weakness before there's enough dysfunction to cause injury or pain. Okay, so that's it for today. I hope that was helpful for somebody, and I will talk to you soon.